I will show you some few cases just to give you the idea of what we have to do with the TIA. The first two cases are two cases treated with the Pascal system. This was a patient, female, 83 years old, with breast cancer, non-Hodgkin lymphoma. In 2023, we discovered a functional mitral regurgitation, severe functional mitral regurgitation. Of course, she was old. She was with the previous radio and chemotherapy. She was, of course, at high surgical risk. So we decided to proceed with the Pascal. And you can see this is a typical functional MR with a severe jet on a A2P2 position. You can clearly see the tether of the leaflet. And this is the 3D reconstruction in which you can see the gap of coaptation just here in an A2P2 position. And there is also a rupture recorded that you can see comes into the actual site. So, as I already explained it, the important thing is to go perpendicular in both in two chambers view and LVOT view. We cloak the device in the end-phase 3D view. And then you can see here the rotation of the clip of the Pascal device at the angio, and the rotation even at the in the echo. Okay. Then we are doing the leaflet capture. So we are just with the leaflet that are lying on both the arms. You go down with the clasp to catch and secure the leaflet, and then you close the device. You can see here very well the clasp that are down, that are bouncing together with the leaflet, and this means that we have a good capture. So this is a good sign. And this was the moment of the closure of the device. And then you check the results. If we have the 3D reconstruction with the position in A2P2 position, the device is perpendicular to the coaptation line. We have the double orifice, and this is the result, the 3D color with just really a trivial mitral regurgitation. Okay, this is the result in the X-plane view. So you can clearly see the image without color. You can do the comparison without the color and with the color. The second case, it was a case of degenerative MR, 79 years old male with DMR 4+. He already underwent 2 PCR with drug-eluting stent, and it was on AFib and diabetes. Patient was with a previous cerebral ischemia and Parkinson's disease. So we decided to proceed with the percutaneous treatment. And here you can see the eccentric jet in the LVOT, because we have the flail of A2, of the anterior leaflet, and the eccentric severe mitral regurgitation with the Quand effect on the posterior wall. In the two chambers view, we still can appreciate the severe mitral regurgitation. Of course, in this case, the color says everything. You don't need to deal so much with the ARWA, with PISA or with the quantification of bar, because it's clearly a severe mitral regurgitation. Here you can see the flail of the A2 leaflet. And in this case, we use the independent leaflet capture. So we first capture the anterior leaflet, and then we capture the posterior leaflet by moving a little bit toward the posterior one. This is a capacity of both device, both mitral clip and Pascal can do the independent leaflet capture. I usually don't use this feature because the risk is to distort the valve if you move the device while you are doing and you are using this feature. So my personal experience to try always to do a simultaneous grasping of the valve, and then in case of problem, in particular case very disease or huge flail or prolapse, you can even use the independent leaflet capture. But I didn't use as as my technique of choice. So here we have, after the first implantation, we have still medial eject. We use, in the first case, we use the P10, so the one with the spacer. In this case, we are using Pascal Ace, so this the smaller one. Of course, because of the still severe medial jet, we decided to put a second device in a medial position. When you put a second device, it's, I would say, easier than the first one, because with the angio, you can still have an easier and faster alignment of the device, because you have the reference of the first one. So you can see that we are going with the device closed into the valve, just to avoid any impingement and any interference with the first one. And this is the result after the implantation of the two devices that you can clearly see here, the first one and the second one in the medial position. This is the 3D color result, even here with the trivial mitral regurgitation. And this is the X-plane and the angio findings. So this was another case of a man 85 years old with many multiple risk factor. In 2001, he went to, I'm sorry, because the slides are in Italian. I didn't have the time to change the language, but it's easy, I think, easy to understand. So in 2021, he has an episode of heart failure with discovering of mitral regurgitation 3+. In 2022, he had another episode of heart failure, and at this time with the severe mitral regurgitation. This was the echo findings. You can see here the leaflet that has a good ejection fraction with severe mitral regurgitation due to the tethering of both leaflets with a dilated left atrium. So this was a case of atrial functional mitral regurgitation. And we already seen this image. I already explained the mechanism of mitral regurgitation. This was the septal. So we decide to implant the mitral clip, and we have to choose with 4 different sites. This is a summary and a scheme of when to put one clip or the other. Basically, if you have a shorter leaflet, you have to go with the NT version. That means with the shorter one. If you have enough length of the leaflet, at least 12 millimeters, you can even go with the XT. That is the longer clip. And then when you look at the area of the valve, if you have a smaller area with a small flare, you can go with the narrower that has just 4 millimeters. Or if you have any issue, you can a secondary map, or even for primary MR with large flail or B-leaflet prolapse, you can go with the white version. So it's a combination of these different factors that make the right choice. In this particular case, we have not many issues to go with the XT white, and so we proceed with the implantation of this clip. Okay, we use even in this case, we test the grippers when we are in the atrium. So in case you need the independent grasping, you know which is the button, I would say, that you have to activate to use one grippers, the posterior or the anterior gripper. Here you can see that we are a little bit counterclockwise rotated. So we apply a clockwise rotation, and you can nicely see that the clip is now perpendicular to the coaptation line. So this is the clocking. Then we go down into the ventricle. We check the trajectory. Okay, we check the trajectory. We have to be perpendicular, both in LVOT and two chambers view. We go into the ventricle. We put down the grippers, and then we close the clip. You see here the moment of the closure of the device. And this is the result after one clip implantation. You do all the evaluation and you release the clip. Okay, and then you check, after you release the clip, you check again your result. As you can see, we have, after releasing the clip, we have a recurrence of MR in the medial portion. So at this time, you have to evaluate together with your echographer, and taking account the patient that you are dealing with, so the general condition, left ventricle, comorbidities, pressure, the rhythms, heart rate. When you take into account all this stuff, you can decide if to put another clip or to leave the result. As you may know, there are many studies that demonstrate that achieving a better result, so reducing as much as possible, at least less than 2 plus MR, give us the best results, even if you pay a little bit in terms of mitral valve gradient. So the message is that it is very important to reduce as much as possible mitral regurgitation. And in fact, in these cases, we decided to put a second clip, and we went with the XT version. It was the longest but narrowest clip. We put it, as you can see, we go really near to the first one, but in the middle part. And this was the result after the second clip implantation. So in a very easy way, we reduce much more better results, and so we were much happier of the result. Here you can see the 3D color that shows trivial mitral regurgitation, and in 3D reconstruction, in which you can clearly see both the two clips. This was the first one, and this is the second medial clip implanted. And here it is a comparison between the pre-procedural mitral regurgitation after the first clip implantation and after the second clip implantation. You can see that we have a really good result. So now I will show you the last case, and I finish. I treated this patient 2 days ago. This was a really particular case. It was a 45 years old patient, so very young. It started with fever, shortness of breath, and you already implanted an ICD in 2011, and he still have, we know that the patient has a moderate MR. He had blood test abnormality. You can see the white blood cells raised, CRP elevated, And at EKG, we have tachycardia without any specific alteration, with good pressure. Chest X-ray, we have multiple confluent parenchymal density in the middle of right lung fields. So I will try to go a little bit faster, and so I just skip about the previous examination because it was investigated with cardiac magnetic resonance because of arrhythmias in the past. This was the reason why it put an ICD. And we skip to the recent medical history. In November 2024, he had a transthoracic echo with mitral valve prolapse of the leaflet with a moderate mitral regurgitation. In February 2025, he got a pneumonia with respiratory and heart failure, and was admitted to the hospital and was treated with non-invasive ventilation. But at the transthoracic echo, we found a mitral valve failure of the posterior leaflet with a severe mitral regurgitation. And I will show you that severe is just, diminutive, I would say. On March 2025, it was transferred to cardiac surgery units. And I will show you the result of TEE with this large flail with incredible and massive, I would say, mitral regurgitation. You can see the flail gap. It's 12 millimeters. And here in the LVOT, you can see the huge mitral regurgitation due to the flail of the posterior leaflet of all the P2 segments. This is the same image, but when we see the two chambers view and the X-plane view, that shows always the huge mitral regurgitation. And this is a reconstruction with the touch view modality that is given us by the EPIC, the Philips EPIC echo machine. And these are all the beautiful images that our echo guys do. Then we were not sure that all the disease were due to the pneumonia. So he underwent a chest CT scan, and as you can see, he has a completely destroyed lung, and it was due to pulmonary fibrosis because the patient deal with chemical products during his work. So there are many consolidations. So for this reason, we made a NAT team, and we judged the patient high risk for surgical intervention. The problem was that the patient was intubated because it was not able to do it to breathe alone, and of course, surgeon doesn't give us any chance to treat him. So we decide in a heart team that it was very important to talk all together with the anesthesiologist, with the surgeon, with cardiac surgeon, at intervention and echocardiographer. We decide to proceed with the percutaneous repair. Of course, percutaneous repair is less invasive. You have not to go in cardiac arrest. You have not to do extra corporeal circulation. So, of course, the impact of a transcatheter treatment, it's really less invasive than surgery. Of course, we do this case. We have done this case with standby of the surgeon. because in case of unsuccessful tear or in case of complication during the procedure, the operatory room was ready to treat the patient. Of course, he has normal coronary artery, and then I will show the percutaneous procedure. We decide, of course, to go with the mitral clip XT wide. As usual, I try to do a simultaneous grasping of the leaflet, and of course, it was impossible to grasp the leaflet simultaneously, because you can see, even if the trajectory it's correct, we are perpendicular to the valve. We are very aligned here at 3D and in the 3D reconstruction. It was impossible to do the grasping. So my technique, the technique I used, was to grasp first the posterior leaflet. That was the leaflet where the flail were present. So I grasped the posterior leaflet. I moved the clip towards the anterior leaflet, trying to grasp it. And then here you can see the clip closed, and the touch view reconstruction with a clip in the A2P2 position in the medial part of A2P2. Of course, with one clip, we still have a huge prolapse flail of the still the P2 lateral segment with still a huge mitral regurgitation. So we went on with a second clip with another XT wide clip. We released the first one, and you see that the clip is moving because we have so much tissue, but still it is really severe mitral regurgitation. So we went with the second clip, and it was a little bit easier, of course, because we already have the leaflet approximated. We are aligned at the clip by following the angel and giving to the second clip the same orientation of the first one. And we were able to do the grasping of both leaflets. So we check the result after the second clip implantation, and we decide to remove it. And I will show now the result of the procedure. We have here the two clip implanted with two small jets, one medial and another smaller lateral jet. The mean gradient was 5 millimeter of mercury, and even at 3D you can see that there is trivial or mild mitral regurgitation. We were really happy because the patient was extubated 24 hours after, and I will let you with the image of the severe and the severe preprocedural mitral regurgitation, the result after the first clip implanted, moderate to severe, and then the final result after two clip implanted. So this was my team. Now one of my best fellows is there with you in Cleveland.
It's a beautiful time.
It was a beautiful